Shirley Fenton, the Managing Director of the Waterloo Institute for Health Informatics Research. Are we on? Okay, good. Oh, that sounds better. I'd like to welcome everyone to this seminar provided by the Waterloo Institute for Health Informatics Research. It focuses on health informatics and the experts that are doing research in this area. I have a few commercial announcements before we start, I'm sorry. First of all, our next seminar will be on March the 11th. We will have the room number correct. It's Davis Center 1304 right here. But the time is different. It will be from 1 to 2. And Chris-Ann DeMarco, a professor in the David R. Cheriton School of Computer Science, will be speaking on where computer science, linguistics, and biology meet, using lexical chaining to analyze biomedical text. Chris-Ann has spoken for us before. She's an excellent speaker, and I'm sure you will enjoy that. Our next Smarter Health seminar will be later this month on Wednesday, February the 25th, and Brendan Seaton, who is the president of ITAC Health, will be speaking on health informatics, tomorrow's industry. Brendan is well known to us. He helps us a lot with the Institute, and I'm sure that this will be a very enjoyable and interesting talk. And continuing on with the eHealth theme, we have several workshops coming up in April, eHealth Risk Workshop Series that focuses on eHealth risk, privacy, and security, and these will be held April the 14th to 16th. So we're taking registrations now. Please let your colleagues know or your graduate students. And we have 2 boot camps coming up in health informatics. One in May, which will be focused or devoted to health information management professionals, and one in June, which is our regular boot camp, and that one will be held at the University of Waterloo. Registrations are open for those 2 events as well. So without any further ado, I'm going to turn the mic over to Maher Shenouda, who will introduce our speaker.
Good afternoon and welcome everyone. It's my pleasure to introduce our speaker today, Dominic Covvey. He's a professor and the founding director of the Waterloo Institute for Health Informatics Research at the University of Waterloo and of the National Institutes of Health Informatics for Education and Research. Dominic research focuses on the representation and analysis of healthcare workflow, the definition of competencies and curricula in health informatics, and the design of the electronic health record. Dominic is a fellow of the American College of Medical Informatics and of the Healthcare Information and Management Systems Society. Today, Dominic will present latest data of surveying the state of infrastructural systems in Ontario hospitals, and will talk about building the eHealth edifice from the 2nd story down. Welcome, Dominic.
So welcome, and to people who are coming by webcast, glad to have you here. My talk today will be primarily about the infrastructural area, but to set that up, I'll be giving you a couple of definitions and background information that should help to understand some of the issues. I speak to you as a very frustrated individual in this field with regard to what I'm dealing with, and you'll probably get the sense of that, but I'm very interested to your challenges about my frustration, and be happy to discuss those at the end. We have plenty of time for questions. Talk about the motivation and progress here in Ontario. I'll give you an overview of some concepts and projects. Identify some of the key gaps in this field, particularly related to human resources. Look at the concept of the architecture of the system versus what's really happening, and talk to you about some of the lessons and issues and so on that I'd like to share with you, finishing with a bit of unsolicited advice. Our motivations here, if you look at what's being done around the world, and only a few years ago everyone was raving about the work that was being done by the National Health Service in Britain and the Australian Health Service and a variety of countries, but if you look at really what's happening, and by the way, this has been a characteristic of this field, that our promise, our hype, is way beyond what we actually ever produce. For example, Toronto Star in 2005 said the whole move to electronic records is behind here. Well, that's nothing new. It's the same everywhere in the world. United Kingdom's ambitious multi-billion-dollar program is running into trouble. Health Connect project, it's unraveled over the last 6 months, and there have been multiple articles on this, including in the British Medical Journal. In the United States, the RIOs are still mostly a dream, the Regional Health Information Organizations. One example, those I've spoken to want to immediately get into doing something, but they don't spend the crucial time getting the community together to talk about why they're doing it. That's a common theme of the lack of a business case, business reason for what we're doing. And some recent information, a $13 billion overhaul of the NHS system has suffered so many problems that hospitals have struggled to keep track of people requiring operations and so on. And then some even more recent ones, the NHS Connecting for Health, the agency has revealed a number of severe faults in the system. And those faults are growing in the system. And finally, in January 22nd, after 2 months of serious discussion, the Dutch health minister announced that in the Dutch parliament that the implementation of a national EHR will be postponed. And I put the text of that below here. It's mainly focused around privacy, of a failure to deal with privacy. Another article says we have 16 million people and only 300,000 have complained. But nonetheless, this is what happens when key issues aren't fully addressed. So picture out of this, there's trouble all over the world. There's no secret methodology or, and we have to ask the question, why isn't it better than this? In terms of Ontario, we've achieved a lot, actually. First of all, I'd like to point out that the concept of eHealth, I like to think of it not so much as electronic health. It's better ways of doing things in the health system, not just introducing computerization, but better processes, better products, better everything in the health system. We've come a long way. We have an award-winning telehealth system. It's gotten many kudos internationally. Our public health work has progressed immensely. There is some order gradually being put on eHealth systems in hospitals. There's less everybody doing it on his or her own, but rather some coordination and thinking across multiple institutions, particularly with the new regional organizations. There are some business-driven projects. For example, the wait time information system has a specific objective. If you look at the newest version of the eHealth strategy, it hasn't achieved it yet, but nonetheless, it has a specific reason why it's being done, and that is to shorten the waits people have for crucial services. Lots of schools are opening up. A few of them are named there. McMaster, I noticed that Norm Archer is sitting here. Welcome. And started a program at McMaster, which is called eHealth, which I thought was a different and a nicer approach to the naming, as you'll see. All hospitals are now linked into a secure network. We've got some great projects underway. Diambetes has done wonderful work in the southwestern Ontario related to picture archiving and communication systems. Matt Anderson, again, while he was CIO in the Central Lynn, was doing amazing work related to community care access centers and the e-referral capabilities. And there's some really great people out there, although not enough. Unfortunately, we have a long way to go, and not everyone is aware that the journey will be arduous. I keep seeing estimates and promises, and I don't think the estimates are realistic or the promises will be delivered. Just some concepts so we can all speak with the same language here. I've used a term throughout here, call them superstructural systems. You use superstructure as something as the upper part of it. These are shareable systems, registries, repositories at a provincial, well, actually regional, provincial, or national level. They're intended as key sources of information, so we push information into these repositories. Some of them are very simple. They could be a list of legal health facilities or of care providers, but they can also be people with cancer. They can be radiographs in these various repositories and registries. They are there so that we can quickly assemble an electronic health record, which is supposed to be a womb-to-tomb view of every aspect of the health system hitting on an individual. And that's really the primary goal of the superstructure. And some examples, the Ontario Laboratories, that should be IES, Laboratories Information System, the Ontario Drug Benefit System, which are very primitive. And in fact, in the new eHealth strategy, it points out we spent over $80 million so far on OLIS, as that first one is known, and we still don't see much out of it. Superstructure supporting systems support these systems so they operate efficiently. So it could be technology. One technology is the HIAL, the Health Information Access Layer, the various integration capabilities that allow you to pull these superstructural elements together and communicate them to the person inquiring for information. Among them, by the way, is the Electronic Master Patient Index. I don't want to leave anybody behind with some of these short forms here. This is a way of merging records that may come from multiple institutions, merging them on the identity of the patient through a variety of characteristics of the patient. Since different institutions have their own unique record numbers, you can't use a unique record number to do that. And you probably want to cross-check anyway in case somebody messed up the record number. Infrastructural systems are defining as those systems are the feeders into the superstructure. They also do something in our institutions and offices and clinics, which is to support daily operations. So these are typically online transaction processing systems. OLTP is a term. And they capture data, hopefully good data that we need. Many examples of them: laboratory information systems, radiology information systems with picture archiving and communication systems, pharmacy systems, and so on. Lots and lots and lots of those. I could have filled out a page with the number of ISs that exist. A concept of business-driven e-health programs. This is programs that are linked to a valued outcome. And one thing I was pleased in the new e-health strategy of Ontario is that there is a movement towards that, to actually link what we're doing to business outcomes. Over the last several years, most things have been linked to process, like when we'll get the system built, will we get it built on time, we get, when will it be available, but not what will it do for the health system. So that's a major improvement to begin to look at that. There's a business objective whose achievement we are trying to deal with through the system that we're putting in. And strategy, again, which is in the new eHealth strategy, a significant improvement, is an articulation of specific, measurable business goals. By business, I don't mean administration. I mean any kind of operational part of the health system, clinical goals, for example, to help people with diabetes actually live longer and better lives. So some example of a business goal to improve the healthcare access in keeping with national standards. That's what the wait time information system is about. And I've named a few of those different systems that are there. Some of the eHealth projects that have been done at these various levels include the provincial superstructural projects, the OLIS, OLIS, ODB, wait time, e-physician project under Ontario MD, Public Health Information System, and the telehealth network. So these are at the superstructural level, although arguably the telehealth network could be put almost anywhere in the structure. So it's sort of a technology of operations for remote healthcare, and it could also be put at the bottom level of infrastructure. A very successful project. Some the projects or systems that support the superstructure: the Electronic Master Patient Index, client registries and provider registries, the networks that have been put in a big challenge to network all of our institutions, and then certain applications on those networks like secure email so that we can maintain the privacy of patients. The provincial strategies, there are many of them, and I put quotes around it because until now, most provincial strategies have really been statements of logistical operational objectives, not at all a strategy. And that's a problem because we haven't been focusing on what we're trying to achieve, but rather on the process of achieving it, which is not really something we should be basing anything on. Of course, there's planning going on, and there is a purported strategy about the electronic health record. If you can find it, let me know about it. There are many management systems that are going on. The report card for the institutions, a performance management system. The infrastructural capabilities are actual, in place, and usable online transaction processing systems that feed into the EHR. And of course, the human resource capacity, something which has been pretty well left out of everything to date. I want to point out that one of the problems we have in this field is an appropriate vocabulary about who are the players and what do they do. And a lot of confusion has been created by organizations that have certain objectives. If you look at this, though, from the vantage point of reality and a structure of vocabulary that makes some sense, we have many people who are members of the eHealth team. They include health informatics professionals, which are highly trained, hopefully, health information management professionals, many technical professionals like database managers and network managers, and others too, business professionals, people who understand healthcare and are in there to make sure that what we do is really appropriate to healthcare, clinicians, for example. We all are working towards applying concepts, methods, and tools that are essentially coming out of areas like health informatics to improving the efficiency and effectiveness of the health system. Efficiency, better processes, effectiveness, better care. Among those are health informaticians and health informatics professionals, they might be called as well. The issue here is this is actually a well-defined discipline at this point, and defined to the extent that we've even differentiated between the people who apply this discipline versus the people who actually develop the concepts and methods. And there are people, of course, who are hybrids that do both. We call the first group applied health informaticians. They're the people who understand the concepts and apply them in real operations and make them work. Then we've got the people with for a better term would be called research and development health informaticians. They are the people who design and do all this and who also teach and do research. And of course, there are specialists within these domains. A new discipline has emerged among the academies of medicine in the United States, actually the boards of medicine in the United States, which is a clinical informatician designation, which is going to be as proposed as a subspecialty in medicine. So these are people who will deeply understand clinical informatics. They know very little about the business side of the shop, for example. Of course, there are many technical professionals of many types. It could be people who do your database, or people who use or show you how to use or implement productivity tools, office systems, people who handle the hardware, networking, and also methodologists, people like project managers and so on that do training, do documentation. These are people who apply methodologies and become an important part of the team. Health information management professionals, these are people who have been classically in the health records department, who really are one of the few professional groups that really understand health information and things like knowledge management. They're a crucial part because that's often a very strong weakness, if you can use those two words together, in our eHealth teams, and many other professionals that make up the eHealth teams. Where are the gaps? What's wrong here? Up till now, we haven't had cogent business drivers for what we're doing. So I was on a board called eHARB, Electronic Health Alignment Review Board, which, by the way, was shut down because I don't think too many people are interested in external review of what's going on. On that board, we pointed out that almost every project we looked at had no business reason for existing. And that's very upsetting if you're putting the public's money to it, because you don't know what the outcomes are going to be. There are many gaps in institutions, and I'll give you some data on that. Lack of systems, poor systems, legacy systems. Now, some people, the one definition, Peter, I'm sure knows, a definition of a legacy system is one that works, right? But nonetheless, some of these systems are so old they can't do what we need to do in communicating with other systems. And they're written in languages that have been retired. Big problem. We have a too narrow definition of information services, and often people talk about information and communications technology, or ICT, or the IT department. We have very little dependence on the technological issues today. That's not where the problems are. By and large, where the problems are in an area called the cofactors of technology, the complementary factors that make technology effective. And I'll talk about those. Things like process reengineering, management of change, training, and so on. Really, really important problem that really you don't see. And by the way, on reviewing the new health strategy, I didn't see anything about this. So that's an interesting challenge right there. We have an inadequate competent complement. We know we have lots of people, but few of them are at the higher echelons here of people who are really expert in health information management or health informatics. So we do need database managers, and ultimately we want database managers that truly understand the nature of this domain and informatics and so on. But right now we need key people that are completely absent from the system who really know what's going on. And the consequence of that is an abnormal hypertrophy of the use of consultants in the health system. People who charge $3 for every dollar of actual work because it goes to profit and maintenance of their organizations, and go away at the end. They don't stay within the organizations. That's a big deficit when we're putting huge money into something and not getting our worth from it. So that's a big problem we'll come back to. There's a lack of evidence that the whole investment in this thing really is worthwhile. There's almost no evidence. One of the few really good studies was done at McMaster University by Brian Haynes and Haynes and Garg. Garg, I think, was the first author. And it points out that we can show process improvements, but there's no evidence of outcome improvements from the use of technologies. And in many cases, we can't even show we've improved the process. How do we sell these systems? And how do we titrate the amount of investment versus effect if we don't know the effect? How do I go to a CEO and say, you're spending 2% of your budget, you should be spending 5% of your budget on this technology, and here are the reasons, and I don't have those reasons because these will make certain outcome differences, and I can't show the person the outcome differences. Really, in the health system overall, we're investing far too little in this whole area, not just technology, because that's the lesser of the important thing, but all of these other factors that make technology effective. If there's anything called a learning organization, this book harks back a while, called The Fifth Discipline by Senge. If there's anything that is a learning organization, it's healthcare organizations. They're information enterprises that constantly learn and apply what's going on. There's nothing quite as strong as that in all the different kinds of enterprises, but we are totally inadequately supported by information technology. So if you think of information as a blood, a nutrient that runs around the system, we've got major ischemia in our system, major lack of nutrients that actually supply the tissue. Inadequate collaboration. Still, a lot of people do it on their own. That's crazy, especially for small hospitals. It's nuts. We've got to get together. We have 4 hospitals really in the region, 3 in the Lynn, I think, and they're all in different systems. 2 of them are in the same vendor, but totally differently implemented. And that's been known for 10 years because I was part of a study 10 years or more ago that actually identified that problem. It's never been fixed. It may be now. Too much centralization, and unfortunately, that's another effect of the current eHealth strategy. We seem to think we can do these things under command and control strategies, while virtually everybody that's been successful in this area have used different management strategies. They're grassroots oriented, that involve people, that actually take advantage of the value of the people rather than just telling them what to do and how to do it. There's an awful lot of secrecy. Finally, we get to see after 2 years the eHealth plan. I was one of the fortunate people who actually received a letter inviting me to an early view of the eHealth plan, but that was sent out by mistake, and we were all told, I'm sorry, you got the wrong letter. Interesting. 2 years that there's been no input from quite a few people in this province and country with respect to the eHealth strategy. And the fear of critique. I think one thing you learn as an academic, and maybe, I don't know if other people don't learn this, is that through criticism, you get stronger. You actually find your flaws and correct them. You stand in front of a group of people at grand rounds at Toronto General, and you make a mistake. You don't make that mistake again, and the next time you come back, you're a lot better equipped than you were the first time. I mean, we should have a culture of criticality, not mean criticality, but improvement criticality. And unfortunately, eHealth strategies and groups in eHealth Ontario and so on, there has been an issue in all of these programs related to really taking, absorbing, and using the criticism. We're past the time for administrative input. That's nonsense. It's got to be that people who know how to deal with things actually implement them or make those things be done the proper way. Too much still of not invented here. We're constantly creating systems that already exist in other countries and sometimes even in this country. And so far, our LINs in Ontario are a nice concept. The question is, will they really emerge as being a way of bringing the institutions together fully? And that's up for test. No one can really fully answer that one now. The research you see shows that the real impacts of technology come only when soft factors are dealt with. One industry study actually found that the thing that made the difference in one sector was not the investment amount of dollars in the technology, but the fact that one group of companies that was successful by a variety of measures invested $3 to $4. For every dollar it invested in the technology, it invested $3 to $4 in the cofactors of the technology. That was what showed as the difference. These cofactors, I've mentioned a few, team building, community building is really a better word, motivation, management of change, process and product re-engineering, organizational and HR restructuring, training, and education. This comes first, not after, but you know, where's the money for this? I've given talks about this at international meetings. And I had one time where a CIO stood up and was very angrily saying to me, well, how can I afford to invest in these factors, these cofactors, when I can't even afford the technology? And my answer was, it's called competence. I mean, if somebody gave you a car, but you couldn't afford the gas or the driving lessons, is it competent to start using that car to try to make it work for you? Certainly doesn't meet licensing requirements. There's virtually no evidence that this stuff, unfortunately, that this stuff produces outcomes that are improved. I want to look at some actual data now on which this is based. And I want to recognize here very explicitly a number of people. The Hospital's eHealth Council of the OHA, chaired by Pat Campbell, and there's a whole membership of that. The OHA contributors included Anthony, I don't know, there should be a colon there, Anthony Yonker, at least in the second year of the study. The main grid, if you want, the grinding wheel in this study is Martha Murray, who, without his work, none of this would have been possible. And two consultant groups, Praxia and Hay, Dan Gordon, a very well-known person in the field, and Adam Topp from Hay. Dan is from Praxia. And they achieved, the group achieved an over 94% response rate in Ontario, which is almost unbelievable, and good data as well. I want to point out that one of the big issues that comes out of this is the issue that we have inadequate eHealth human resources within our system. Unfortunately, terminology as what we need is not clear. It's called health professionals. Numbers have been needed between 2,000 and 15,000 across the country. I don't know the number for Ontario, but SSHA, when it existed, it's now been absorbed by eHealth Ontario, used a number of 2,000. But we only produce order of 100 people a year in the country who are true health informatics backgrounds, who have true health informatics backgrounds. We have some issues. There's still a lot of unclarity or disagreement about what people need to know, what roles they need to play. There's no certification yet, although COACH is introducing the FHIMSS certification in Canada. Few programs are easily accessible, particularly by people who are working. The only way they can do it is through distance learning, and there's very little distance learning. There's only one master's program in the country, and no undergraduate programs that have a distance program for people who are already in the field and working and have kiddies at home and things like that. Big compensation gap often shows itself between industry and consultants, particularly of what they get paid. Little funding for staff education, a few $1,000s in many departments per year, not enough to educate one person, let alone a whole department. There are, of course, exceptions to every one of these. And I think a failure of leadership to recognize these things and to take action on it. We looked at the concept of readiness here, and using a military concept that readiness means you've got a certain number of tanks functional and ready to move, a certain number of aircraft that can be flown today, a number of the pilots that you need to fly them, the support personnel, and so on. The idea was to look at readiness as, do you have the pieces necessary to do something? And exists at all levels. And what we only focused on here was hospitals. We simply did not go beyond that. These are the feeder systems where data and information are captured. So, for example, you want to see physicians' office systems in the list. And we want to, be able to make sure that there's availability and good quality data in these systems. One thing that immediately boggles the whole thing is we do not yet have a data standard implemented across the province. So when you share information, your word and your word are different words for the same thing, and that creates amazing problems. Your lab results can be different from somebody else's on the same blood lab results as well. So some of the issues in institutions in Ontario that we learned: incomplete suites of systems. They don't have a complete set of systems that would support a hospital. And then when you look within the system, incomplete data within the system. Legacy technologies, hard to maintain, hard to integrate among different systems or interface between different systems. Lack of data standards, very challenging to do integration, particularly the institutions have little experience in this. The costs are high, there are vendor barriers to it, including the old systems barriers. Inadequate investment. There's not enough money to do more than get the basics done inside, at least at the perception of the institution. And of course, the complement problem, the competent complement problem. So to just give you a little bit of data here, and this is a large study. It's available online through the OHA. What you'll see is the gap is red. It's probably the easiest thing, and mostly this will be a study in visual red, except this one's blue. This is a plot, if you want, of the index scores of hospitals, how well they did. This would be that they were ready, and this is less than ready as you go down here, and this is kind of horribly unready at this end. The number of hospitals is up here, and like the maximum got to be 9, but if you sum all this up, you'll get on the order of about 150 hospitals in the province of Ontario. And it's a score, and every score has a weakness, but the score is actually broken out as to how it was computed if you're interested in getting that. This was in a 2006 study where we looked at results reporting in institutions. The ones that did it or had the capability are in blue, and this is hospitals across the bottom here. And this is the ones that were less ready in this, like they maybe had a system, weren't using it, or it wasn't ready, or some aspect of it. So you see this drop off as you go to the right here. This is just an order of having it. The point is that it looks like 40% at least of the capabilities needed across the hospitals in this group, this happens to be a community hospital group, were actually missing in order to accomplish what was needed to address the needs of the eHealth integration towards the EHR. And when you look at regional data sharing, it's disastrous. There are fewer, I think, than 1/3 integrated under here of the institutions have adequate systems. So you see almost entirely gaps with a few exceptions. We have one hospital here that seems to be ready for that type of capability. This is another way of looking at, again, 2006, a spider diagram where we just put these things around the edge. Interestingly, these are the operational systems like order entry, results reporting, some of the networking within the institutions. And over here are some of the other factors like proper regional governance, interoperability, EMPI, this ability to match up records from different locations, the ability to share data, and the HR leadership. And what you know is there's a lot of red on this side of the diagram, indicating we've got bigger problems, although significant problems on the right side, your right side of the diagram. We have bigger problems over here in terms of the ability to do the things that would connect the institutions to each other and to an electronic health record superstructure. These were measured in 2 years using the same techniques and again, similar high levels of response, order of 95%. And the red one was where it was in 2006, the blue one in 2007. You'll note there is some improvement. There are more institutions that have higher scores here, and things have shifted slightly to the right, so there is improvement. Now start calculating based on this and do a little math and find out how long it will take everybody to be ready, and then you get scared because it's going to take a while at this rate. It'll just inch up on this, and the tail of this curve has not really changed much at all. So there'll be the have-nots within the province. Here's an example of a capability gap. Oh no, that's the diagram explaining how it works in case I forget. This just shows some of the eHealth adoption things and looks at things like registration record. Pretty well, the average indicator score pretty high this year, but only slightly different between the 2 years. Some others are lower, so the amount of order entry is minimal. I always worry about this being overstated because it's not all absolutely clear. I should make it clear. Very little of this is actually clinician order entry. It's often clerical order entry. But again, very little difference between the 2 years. So we're not seeing amazing differences to improve the situation in a whole year. And the methods hospitals are using to share clinical information, you can see that many are not sharing, which is the blue area here. Some are using remote access or similar tool, so keyboard-based entry into the thing. An interoperable electronic system, which would be the green, relatively few, with other hospitals, with consulting physicians in the community, with other healthcare organizations. So we can see some of the issues there very, very clearly. This is point of care order entry. Shows that in that particular area, if you do the spider diagram, when you've got a few more web points here from the spider did for us. Very little difference between the 2 years, where the red, 2006, is slightly improved by 2007. By the way, the negative things that occur in this are probably just the nature of the data, as opposed, nobody's gone backwards, I don't think. And so on. There's another one for point of care order entry. I tried to get some information. We've been working quite strongly with the Branham Group, which are also involved in capturing this information. And they produce a variety of reports related to the current state of ICT, is the way they put it, in the health system. They see an investment level of 1.8 to 2.5%. We were looking at some data, people tried to say it was about 3%. We've never seen that level of data. They've confirmed that the level is really unbelievably low. Most institutions in the United States are super 3.5%. I work with Mount Sinai in New York, and that was at least 15, 12 years ago, and they had a 7.58% of their budget, and that's a big, big institution. So one, the level of investment is very small, but if you take 2.5% of University Health Network's budget and dedicate it to IT, you're going to get a lot of stuff. But if you take a little East Podunk General Hospital that's got 33 beds and take 2.5%, you're lucky if you can afford the coffee warmer. I mean, there's a huge issue here related to the ability of smaller institutions to operate within these budget fiducials. And the only solution I know to that, because there's none within the budget, is to join up with other institutions. There are many incomplete systems from there, and aging has been a problem for them with almost no interoperability. Large hospitals have pretty good budgets, but the small hospitals don't. And overall, the conclusion they come to, the same conclusion we come to, is that we need to do something about creating shared systems. And there are different models of that. One is the command and control model. We put everybody, I've actually heard a member of the Ministry of Health say, everybody in Ontario on one vendor system. And anyone that's at risk any health system on a single vendor has got to be somewhat out of their minds. But we do need to cut down the number of systems and create regional groups or even multi-regional groups to deal with this. Problem in Ontario, we've had a very low level of investment when other industries have much more. Most of our investment has been in these superstructural systems like OLIS and ODB. But this survey shows a gap in the EHR capability related to hospitals, which is the largest investment sector in this industry in Canada. And it even points out that basic deficiencies exist, not just contributed to electronic health record, but having the systems to operate the institution in 2009 is a problem. But there's no money in any budget for this. In fact, one thing that was put forward in early versions of the eHealth strategy was that hospitals were going to contribute money to the superstructural level of this thing. I mean, I don't know how this can happen. This is a huge boggle in terms of the ability to get money into the system. And I'm not saying only money is the problem. I've said that before. It's got to be also better leadership and better spending and all of those kinds of things. What this means, though, is feeder systems can't feed the electronic health record. And if we have more than fantasy, then we need to deal with this. But not just throw money. We need to do some intelligent intervention in this thing. So some of the conclusions. Without question, we have a problem at the local or infrastructural level. It is a significant, multi-hundreds of millions of dollar problem that's unaddressed. And even if it's addressed at the rate it's being addressed, it'll effectively be unaddressed. Why we're there, and we did get survey data back. People said it was because of inadequate budgets and lack of people to actually provide leadership. It's actual data from our surveys. But you could argue it's a million things. You could say, well, people just haven't invested well, or maybe you should have more private sector. I don't know all the reasons, but I do know that we do have a gap, and it needs to be corrected. How we should deal with that gap, again, is an issue for discussion and debate and formulation, but we have to fix it. Because at the very least, forgetting the fact that institutions are not outfitted for the capability to be able to deliver their ordinary processes efficiently, we're going to have an empty health record the way this is going. People are not going to be able to do the feeding to it. One of the things I point out is this is a diagram, my revision of a diagram that was used in the earlier eHealth strategy. And it had pillars of these superstructural systems that would somehow connect and support the EHR built on the local systems. And the truth of this situation is this, that we've got many holes, and this is probably being kind to it. The result is that there's a real question as to what we're doing here. So we're putting all of our money at this level here, pretty well, and almost nothing at this level, at the bottom level, or infrastructural level. This is kind of an interesting diagram. I've had it for many years. This is the new building. You think of this as the eHealth strategy, or the eHealth in hospitals. This is a building the way the president designed it. Those little parapets and flags, and nice building. This is where the architect got it and created a glass structure here with many floors. This is where the local zoning board modified to get green space, and here's what was actually built, a temporary structure. And we have that danger facing us. Some of the lessons that have been taught, and I don't think have been learned, is that technology alone is inadequate, and it leads to failure if we focus on it. Projects must have business drivers so that enough money is put in to achieve the business objective, and we measure it by achieving it. And if it goes badly, we fix it or get rid of it. We don't keep putting money into these things. Someday it'll work. I mean, the OLIS project has gone through about 5 levels of obsolescence in the 10 or 12 years that it's been in development. I mean, it's nuts to have systems of that type that go that long. I mean, we've got to think in much shorter terms and more iterative development processes, rather than really never delivering because we keep doing the same thing. We need good sponsorship, people who believe that we're going to get the objectives we've claimed, good leadership that will actually achieve them, must have clear purpose. And without it, we should stop the projects, not just finish out the contract. We have to restructure information services to get beyond this idea that this whole informatics dimension is technology. It's just a part of it. The real thing is the human side of it, the process side of it, the organizational side of it, and we really need to incorporate this. So how many IS departments in the province have industrial engineers in them? Few. How many have people who are really expert at management of change? Not young people who have read it in the textbook. How many really good project managers we have? We had an earful about that on a phone call with another study that's being done. The project managers are textbook project managers. They've never managed a significant project at the level that it needs to be managed. We have to deliver departments, enterprises. We're past the time of putting systems into hospitals. We're now at the point where we need to put new approaches to healthcare delivery, new department approaches, which are built around systems perhaps, but where the first thing we do is we design the improved health system and support it through the technology. You can't throw this stuff in on the old way you're doing things. Years ago, you had a quotation and thing I wrote that said, if you take a mess and automate it, you get a faster swirling mess. That's all you get. You pave the cow path was another term. We need to get the infrastructure addressed. Now, maybe politicians will get reelected based on achieving the wait time information system thing, but nobody's going to get elected by making sure that Grand River or St. Mary's Hospital has adequate technology. These are very low profile, but they're absolutely essential. How much money, how much leadership goes into this, and how much building on the capabilities we have as well as developing new capabilities. It's essential to form larger cooperatives. We need competent, capable people. We don't have them. I think professionalism is a step, but I worry about the depth of the work that's being done in professionalism. This is certification of professionals. I don't think it matters that we do electronic health. I think what we're trying to do is enable health by whatever means, and one of the means of enablement, or many of the means of enablement, are things like re-engineering and so process re-engineering and product re-engineering. I think focus on the superstructure is still a mistake, but it has to happen. Just at the level that's being invested in is really questionable compared to the infrastructure. We have to develop evidence. Anybody that runs a project doesn't evaluate it from the very beginning, build the evaluation, and the project shouldn't be funded. I notice there's an evaluation mechanism with the eHealth strategy, which is totally unclear about it. Is it at arm's length? Every agency that reviews itself finds eventually that it can declare a victory. That's not what we want. We want to know these things actually delivered by competent assessors. They're evaluators, professional evaluators. There aren't huge numbers of them in the country, and they're running all around doing things, but they are people who really know how to do this and can tell you if you've achieved something or not. Iterative development is crucial. You can't sit back and build a system forever. It should go through many phases, starting with the most important things first. We're still building things by the old waterfall approach to system development. We really haven't learned this one at all. So agile development concepts for those of you who are computing. Another thing you have to do is assume missed approach. If you learn to fly and you're told if you're landing, if you're facing the runway, looking down at it, your mind isn't getting yourself onto the runway. The focus needs to be on what are you going to do if you cannot get onto the runway. You assume missed approach. Where are you going to go if there's a deer on the runway? You're going to go up to 5,000 feet over a certain fix. You're not going to still land. I mean, you can't continue that plan. So you want to get down, but you really need to, we have to think about in these projects, what happens if they don't quite work out? How can we phase them so there's always value at any given stage? And if things go wrong, where's our missed approach point? What do we do? A lot of strategies we have are just gussied up tactics. They don't really focus on anything. We need frameworks, we need goals, we need objectives that are measurable. We obviously need standards and best practices. Most best practices are just my practice. We still don't have what I'll call a repository of best practices. And we need evidence-based policy. And there's movement in those directions. The school in Toronto, is Health Masters of Health Informatics, has focused around policy. So there's something very, very positive happening there, but it still needs yet to be done. I think we need to recognize we don't know everything rather, so we do know something. We don't know everything. And this is crucial in these large projects because often when I look at them, the people who would know certain problems aren't in the project. The first thing you need to do is to recognize what you, meaning whoever you are, you the team, don't know, and get the investment of those other people in the project to bring all of the things to bear that need to be brought to bear. So some of the issues, should be getting to the finish here, get this thing to work. We've constantly focused on eHealth, e-solutions. We're not really understanding where the problems are in the health system and changing the health system and using the eHealth capabilities to do that. I claim we have a do-it gene or build-it gene or a development gene. We always want to do things, but for what? Where's the problem? I can build something, but does it really make a difference? We really don't know what we're building towards. I mean, talk to people about the electronic health record, but what's going to appear on the screen when the emerged doctor actually asks for Mr. Jones' information? What's going to be on there? Is it going to be the crucial information for Mr. Jones? Is it a well-designed view of the record? Something that's been left out so far. There have been sort of voting attempts as to which the data elements have been on there. There's science behind that. It's not being used. There's a failure to articulate a strategic basis for much of this, although the new eHealth strategy does improve on that. Huge underestimation of the effort and cost. The latest figures are 2-point-something billion. I would say that we will not be where we need to be in 2015 without an investment of 3 times that level, conservatively. And to expect money from the hospitals to augment the 2-point-whatever billion, forget it. Centration on superstructural systems rather than local level. Failure to build adequate capacity of people. Depends on consultants. And the ridiculous project planning that still goes on, where you get locked into these contractual processes where everything is secret, you can't critique it, it goes through, and then you can't change it. I mean, this is nuts. Innovation, to introduce innovation, it's almost impossible to introduce innovation. We work with one organization, people we know closely, tried to introduce a new innovative approach to some of the systems, couldn't even get it considered because it wasn't already in 3 institutions somewhere in this country. That doesn't allow anything. So a couple of interventions. And I was interested, there's an expert panel concept in the new eHealth strategy. Of course, question which experts and who's leading it. And is input given or does it make a difference? A lot of stuff ends up in that classical administrative parking lot, a favorite administrative ease term. Parking lot. Nonsense. Some of these things are real and need to be dealt with. You don't go to the military and ask them the question, how many tanks do you need, and say, let's put that in the parking lot, your answer, and we'll give you 3. That doesn't work that way. So we need to estimate the true nature and magnitude of the system change, not the technology change, and what we need to do with eHealth to do that. I don't see that focus generally. Conceptualize and articulate a strategic basis, make sure everything fits into the framework. Develop the transformation of infrastructural systems into eHealth. It's not part of the strategy that I've been able to find. Invest in the development of eHealth human resource capacity. There isn't a strategy, there are statements about the working towards getting more people with the colleges and universities. Look at the number of dollars that have been invested so far, 0. I didn't see the investment that would be made in that case. I don't know if it's included or not. to me, one of the most crucial things is to have people do what we need to do because we're changing people, and it can't be done by machines. We need to re-engineer the processes in the Ministry of Health and eHealth Ontario. Hopefully they're going to deal with that, getting flexibility, real innovation. We've worked on 2 innovation projects of Infoway. They've been absolutely locked down by a classic waterfall approach to development. We can't do the things that are necessary to be done to be able to do innovation. It supports things that are already known and done, not new creation. I hope this doesn't happen in Ontario hospitals, but I played this one as horse hospitals, but the bottom at Guelph, they didn't like it in the veterinary college. But some advice. This is a favorite. Consultants here with the New Insights send them in anyway. Here's my final advice. Fads come and go. And the only real difference is the amount of money and the number of bodies behind them. To some degree, this is a fad. I've been looking at Obama's plans with respect to the United States and health information technology. It's been critiqued by quite a few people. There's a beautiful report out, if you haven't read it yet, about it was published by the National Academies of Medicine. I mentioned it to one of the people here, and it's an excellent report. Where's the title of it? Computational Technology for Effective Healthcare. And it really has been going for 2 years, so it's not just in response to that, but some of the conclusions of this study are, and this is then challenging what we've done, not just what's being applied. It may not be ready to be applied. It says, current efforts aimed at the nationwide deployment in the United States of healthcare IT will not be sufficient to achieve the vision of the 21st century healthcare, and may even set back the cause if these efforts continue wholly without change from their present course. Another conclusion, success will require greater emphasis on providing cognitive support, things like decision support and those kinds of things, rather than just automation of operational processes. And if you want to see a really wonderful report, by the way, this report was chaired by William Stead, Bill Stead at Vanderbilt, and he did a talk in the fall, which is absolutely unbelievable, which showed clinical improvements. And then once in Vanderbilt they showed those clinical improvements, the adoption went like wildfire. Otherwise, we're selling bills of goods with promises, but not reality. So this is a really good report. It's free. You can just download it as a PDF. And if anybody's interested, I can give you the report on this. It's immeasurably more important to determine what we want to accomplish in the health system rather than finessing the approach and the technologies. I read about strategy. I'm interested in Clausewitz and even the ancients. And one book on Vietnam, a really revealing book. Vietnam taught the difference between strategy and war fighting, which is just the process of grinding as opposed to getting somewhere. And we're kind of close to that in some of the things that the United States is involved in, Canada's involved in right now. In Vietnam, they got cold beer and hot music to the front, but they didn't win anything. They didn't do anything. 30, 50,000 Americans died, millions of people, indigenous people, and we lost the war. Strategy means leadership. It comes from the word strategios in Greek, and it means leadership, generalship, more precise. Strategy means goals and outcomes, projects and systems, and I would add to this, and measurable so that you can prove that you actually did them. Electronic health is only the means, not the end. And Winston Churchill's, however beautiful the strategy, you should occasionally look at the results. Thank you very much.
Well, thank you very much, Dominic. That was very, very interesting, and I'm sure the audience has questions, so I will be delighted to get a mic to you so we can record the question or your comments, and just put up your hand and we'll do
Also,
that right
people
away.
in the audience who have done some work in this area might want to even comment.
Sure,
So.
that's for sure. So we could pick on Norm Archer, for example. Norm, do you have a comment?
I have to give you a microphone. Yeah.
Thank you. It's on? I'm never short of words, so maybe you've come to the right place. No, I really enjoyed the talk, and I think it's right on. I really certainly agree with you, and I've worked in this field for a number of years, and I'm just as frustrated as you are. And I certainly agree that we have to do a lot of things, such as improving the number of people that come out that understand eHealth. Incidentally, enable health is a very, very good term, and I'll remember that one, and I'll use it for eHealth. But I certainly agree that there are a lot of projects that are underway, very large projects that are going to get nowhere. The government is spending millions on these projects. And I also agree that it has to come from the grassroots, and that those physicians and clinics and small groups that have success, we should find out who is being successful and figure out how to get the word out when they are successful. Unfortunately, of course, that mitigates against standards across the system. But I really believe that that's the only way we'll make progress. If we impose a large set of standards across the system that everybody must adhere to, it's not going to fly, period. It has to come from the grassroots. So I certainly agree with what you said, Dominic. And I really know we've got a long haul ahead of us.
Just to add a little bit to Norman, if you look at this Ontario's eHealth strategy, which you can get online, they actually, I was quite pleased to see this on page 6 and on, have a series of lessons learned from past eHealth focus. Unfortunately, it's not quantitative. It isn't really grassroots, it's high level. Points out the wonders that have been achieved by Ontario Telemedicine Network. Points out the problems with OLIS and so on. But we need the little guy, you know, the office. I was really impressed with, what's his name? I always think of Rosenall first. Rosenall, Tom Rosenall at Calgary in the study they did. And they came here and gave a presentation where they actually achieved a very, very high adoption through a process that was very humane. So we need to learn about that stuff and use it, not just the technological successes, but these interventional successes. You know, there is good stuff out there, but it's not being built on. It's almost ignored. We also have another one we can pick on from AHS. Do you want to make some comments? To get a microphone here too. Oh, so they've got.
We got more than one from AHS.
Yeah, that's right. Well, yeah.
An online question.
Oh, we have an online question. So,
What role should the LINS take in this transformation?
Which role should what?
what role,
The
what
LINS
role
take.
should the LINS
Oh, the lens.
take in this transformation?
I would say gravitational center. In other words, become the place you must go to in order to move forward with the objective that the LINS coordinate in an intelligent way, assuming they have the knowledge necessary. So one aspect could be the LIN could be the way of bringing at least coordination to what's going on. A second role, I think, would be, if it could be done, intellectual leadership. Things like saying, what kind of people do we need? You know, what are the frameworks we should use? How do you do evaluation? So pushing the concepts that we know are so crucial, having the right people and evaluating what we do, into actual practice. So it's like somebody finally is reading the literature. I'm appalled by the number of people in the field that I speak with that have never read any of the literature, despite 50 to 60 years now of research and work. I was at a meeting related to human resources in which I said, you know, we really need to identify the role called health informatician. I got argument back. Well, I've never heard that term before. How could you be in this field and not hear that term before?
In terms of the LINS, do you see them as their focus should be internal to the LIN, or are they the glue, should they be the glue between regions or among regions?
You know, I was thinking when we started to think it should be like a black hole, but it should have the ability to eject matter again. In other words, it should be that if you think about this, the LIN looks at the health system and it really says, okay, we've got these problems here and there, and we're going to take that problem we've identified at that hospital, which is also common at those other hospitals, and we're going to bring it in, we're going to work out an approach to it, and then we're going to push it back out again using what I'll call canonical approaches, or structured standard approaches to dealing with that. Things we know already work from the research. So if we could have that ability to kind of ingest it and then excrete it in a better form. That's a horrible kind of analogy, but that would be ideal. I'm thinking my cat's throwing up
Yeah.
now.
I guess I see them as working at two levels. One, that they have to address their particular land, the issues within their particular land, and there's probably a strategy that they need to, or a set of strategies to do that. But then they have to, I would think they would have to do extra regional strategies so that we can start to work together.
The lens must work together, particularly almost in a diagram that would, if your lens is here and you've got 3 lenses around you, then you work there a lot and keep moving out. But also looking at the lens that have done better than others. I mean, I look at what Matt Anderson accomplished in Toronto related to e-referral. That's something that should be really a message to everybody. That should become a provincial resource if you want that knowledge and approach. Diane Beattie in London, and I'm sorry I can't name all the people, but yeah, you're right. I mean, they have to go out to the other lens and they have to communicate. So it becomes a community of e-health leadership community among all the lens. And they need to meet regularly, probably every quarter or sooner.
And then some sort of methodology for moving those things out.
And yeah, all kinds of technology to support that and methodologies to support that. But yeah, but you know, that means unprecedented cooperation in the Ontario health system. This basically has been a bunch of competing businesses as long as I've been, you know, in Ontario for 40-something years. Hospitals compete. In fact, I met with a hospital in this region that told me, the CEO told me, that hospital had a certain technology because it was better than everybody else, and he considered it a competitive advantage to have that technology.
Dominic, we have a question here, and we have 3 more on the web
Oh my
waiting
God.
for you.
Okay. Let's do you, and then
Oh, just as a comment, seeing that you solicited, I quite agree with you. I share some of your concerns about the enormous investment that's going to be required, and Infoway is estimating that by 2015 that will require $10 billion in order to get these systems in place to have an interoperable EHR. But the issue that most people don't talk about is the fact that it's going to take another $1.5 to $2 billion each year just to maintain those systems. And so, I mean, the long-term impact of that is a big issue. The other thing that I think is more, and I hate to get philosophical about it, is, but we actually talk about the issue of e-health, but it's defined so differently by so many people. And in fact, it's a moving target. The very fact that technology is so incredibly dynamic means that, you know, as soon as we start trying to measure something, it's obsolete. So, you know, if you want to have a longitudinal look at e-health implementation in the province, the danger is that you're measuring something that, you know, in and of itself is obsolete. So, you know, I think you have to take that just into consideration as well. The other thing, too, is related to adoption of technology, and that, in my mind, is something which, as you mentioned before, in some studies where they've been able to prove that the pull strategy is much more effective than pushing it from the top down, is a really important piece that I don't think we really attend to well. And if you look at the uptake of DI and PACS, you have to wonder, you know, what happened there? Why is it that every hospital has just adopted that and said, well, of course we're going to electronic sort of diagnostic imaging? And it's because there's a business case for it, very clear business case, and because the drivers are the fact that it means a huge lifestyle change for clinicians who are using it. You know, now they don't have to come into Emerge at 2 o'clock in the morning to read an x-ray. So those are pull strategies because there's a very clear value to the people who are involved, both the hospitals and the people who are delivering the services.
very good points. Do you want to take questions from the audience?
The first one is, delighted to see you are challenging the status quo in your usual way, but you don't seem to be challenging the superstructure designs itself, which emulates failed attempts in other jurisdictions. How about challenging the overall assumption that the state is responsible for a cradle-to-grave EHR? Why aren't we transferring the responsibility to the patient and steering this whole thing towards the private sector PHR initiatives?
It sounds like we've got another Republican in the audience. I mean, it is a whole strategy that's beginning to emerge around concepts like the personal health record, where patients become a crucial part of their care. Boy, brand new idea. I mean, that's and commitment. And you can see the work of Kevin Leonard on his One Patient, One Record. There's a meeting coming up in Toronto, push on that. Glover is the other fellow who's been pushing that. I think if the problem could be truly transferred to an informed patient population, it would shift things around. I mean, it would definitely change things. Can the private sector do this? We were at a meeting with IBM the other day, and they talk about a number of instances they've got at-risk selling. Or they give you a system, and they get a percentage of what is achieved, and they're making money on it. I mean, if you look at this stuff, and it did what it was supposed to do, it would actually save lives, get people back to work more quickly, and maybe even save operational money. So the long-term maintenance of these things is not an issue in a business that's doing well because it's properly used its computer technology for intelligence and operations and so on. So I think the trick is to get past this ignition point where you can say, if we do this, it will make a difference, and that's what makes it worthwhile. But beyond that, I don't know how the private sector can play more of a role other than if we can put systems in which show improvements, and the private sector can be rewarded by that. Then they put the systems in and implement them and support them and so on, and we end up with improvements, and they get a percentage of the take. But right now we've got loss, not take. So.
The next question is, how would you make a proper business drive or case in eHealth reform?
How would I make a particular business driver case?
How would you make a proper business drive or case in eHealth reform?
I mean, my structure would be first to really understand. First of all, pick a part of the health system you really can make a difference in. It's another positive of the current eHealth strategy, although it focuses down a great deal. They've chosen diabetes, pharmacy, and one other area as areas of focus. Emergency room waits. So, choose an area where you're going to make a difference. Difference for the patients, a difference for the doctors, a difference for the public system in terms of its cost, or at least of its ability to handle people more efficiently who come in as the volume increases. So the first business case part would be to figure out what I wanted to do with the aspect of the health system I was working on, and then measure its value. Like, if we got fewer people who have lost their vision, pick on optometry, through diabetes, what difference does that make? It makes a difference. I'm sure Graham Strong here could tell us that it could save money, it could save people's productivity and all kinds of things. So measure the health system impacts if you could achieve the proper approach to it. And then this just becomes one of your investments. The IT, the eHealth part just becomes an investment. So I wouldn't build an eHealth investment case. I would build a health system investment case where the enabling things like technologies of various kinds are the things that make a difference. By the way, a technology could be having gene chips that allow us to do better medication for you compared to other people, so personalized medicine. And that saves spending tens of thousands of dollars on a drug that won't work for you, or poisoning you, as the case may be. So those are my thoughts. I want to
There's just one final one from the web. What influence do you think the public might exert? They got docs onto the web.
Say it once more so I can understand the question.
What influence do you think the public might exert?
Well, it can be good or bad. There was the group in the United States that's doing this is ARP, the retired people. Okay, I guess it's called CARP here because we complain a lot. But they are pushing, or have been pushing, through I can't remember the name of the foundation. It's a flower or plant. It just slips me right now. But they have been pushing very, very hard on the concept that all hospitals should have clinician computer-based physician order entry for medications and lab tests, particularly for medications. But what the public doesn't know is that there are studies that show that the introduction of these technologies causes other problems. In other words, these are two-edged swords. They can cut, that way, or they can cut back. And one of the papers showed 25 new types of errors that can occur secondary to a technology like CPOE, computer-based physician order entry. So the role of the public is tricky here, because you can't just get everyone rallying up and say we all want to go, computer-based physician order entry, because that would create a huge issue and not recognize some of the challenges with the technology itself. Every technology I have reviewed has untoward effects. And there's a beautiful paper by Joan Ash on the unintended consequences paper, it's called, the unintended consequences of the use of various technologies. So you have to look at that, and the public typically is not that well informed to do that. I don't know at what level in the system, though. Maybe it's the health system as opposed to the public would be a better push for this, but with the support then of the public based on the experiences they've had of waiting 12 hours in the emergency department. That was in the paper this morning. So, okay, yeah. And then you.
I think that lady had a
Oh,
question.
okay. You're welcome to choose whoever.
You made reference during your talk to the fact that you were against having a single provider and try and enforce that across the system. What are the reasons behind that?
It's that if you read the National Academy study, no one vendor has mastered this, for one thing. And if you look back on the history of this, the failures and acquisitions that have occurred in the marketplace are rampant. So you can't trust it all to one. It's like trusting it all to one bank in the United States right now. You might have gone down with AIG or whatever. AIG is an insurance company, I guess, but we might have gone down with Wachovia or something, Bank of America. You can't trust everything to that. The argument's been made, well, Ontario is just the size of one of the major health systems in the United States, like, for example, Kaiser Permanente. But you don't have the control of the system that Kaiser Permanente has. It's not, Ontario health system is not a Kaiser Permanente. And maybe even within Kaiser Permanente, there's levels of flexibility for proceeding, although some systems are common. So it's the abilities the vendors have to actually deliver things right now. Everyone has major weaknesses. The survivability of the vendor in that situation, and the literally killing of competition. And some of the things that go on in this field related, for example, physician's office, to me, are restraint of trade. That's called illegal. You can't destroy a company just because you want fewer companies in the field. That's illegal. That's a crime. So I think it is wrong to have that focus on a single vendor. Now, maybe it should be always a mix of three or whatever. I mean, even the NHS has different approaches within the country, 5 different approaches, I think. But I think we need to give a lot of thought to that, because this is an evolving field. We're not done. We're just getting to the point where it's becoming useful. There's not great stuff out there. These systems fail. I can give you one horror story after another about failures. So, and very few of them meet current, what I'll call accounting science standards. Ephraim Boritz here runs the center, what's it called again? Anyways, a center related to the review of software systems to see that they actually do what they do. And there are formal processes now. In fact, there are structures and vocabularies and everything for doing that. Almost none of these health systems is subjected to that kind of review. Few of them are even built on good software engineering principles with modern technology and structures that can be maintained, and good documentation is a problem. So we're just at the beginning, and we need to get those things. And maybe as it matures, then we'll have, like we have 3 or 4 main computer companies, although many laptop companies, we may have few vendors and we can then limit it down quite a bit. So back there.
Come back to the poll question a little bit. I'm fairly new to this area, but I was wondering if you could say a little bit more just about when the adoptions go well. And so you mentioned the cognitive supports and the Vanderbilt work and Tom Rosenall's work at Calgary that had high adoption. And I was just wondering if you could say a little bit more about, what were the successful, what was the value, why were those successful? And also if you could just point me also to the Vanderbilt paper you mentioned there's a web address.
It's on our website, hi.waterloo.ca, and you go to archive. Actually, you go to Smarter Health, correct?
No, you can link to it from our website, hi.uwaterloo.ca, and there's a link to the online archive.
It's called HI Alive. And it's one of the Smarter Health series last fall, so it should be easily. Interestingly, I just wrote an email this morning. In the American Medical Informatics Association, there's a group called the POI group, People and Organizational Issues, POI, okay? And what these are the social scientists. It's run by one of the key people I know, and there's a historian. There are cognitive scientists. There are the organizational types and so on. And I usually call them the psychosocial band, okay? This is the people who are invested and knowledgeable and competent in the psychosocial disciplines. And I asked them, could they consider to have a workshop in the next AMIA meeting, American Medical Informatics meeting, on what are the 5 top interventions that make a difference? I don't know them. I don't know the 5 top ones, and neither does the person who's involved in it know. So we'd have to get a group together and say, where's the evidence that certain things have really worked? I can only then give you a sense, okay? Shirley's done some work, and there's a really nice talk on our website by Etienne Wenger, W-E-N-G-E-R, on the concept of a community of practice. And the short story on this is we got involved with the Ministry of Research and Innovation in Ontario, who wanted to build a website to support what they call the commercialization community. Lawyers, companies, researchers, investors, et cetera, about 5 or 6 groups. And they want to build a website. And Don Cowan and I were meeting and said, well, to do what? For whom? I mean, what do you want to accomplish? Well, those weren't really known. And as we said, there's a deeper knowledge base here, and it's the concepts of communities of practice or community of practice that Wenger put forward. And we actually had a workshop on that. So I think the first thing is you need to create this community, this within your institution or between institutions, or a community of people with a common purpose who believe that working together they'll achieve something. So there's a sense of self-esteem about their involvement, a sense of value in the collaboration, all those things. And you build the community first. I think the thing that Rosenthal did, and he's that kind of person, he's a very human person. He's not a techie, he's a physician. He and that group built a community of practice and a goal, and we're working together on this. So that's certainly one, probably the most primitive thing, but I can't tell you for sure. A second part of it is that we have learned a lot about the diffusion of innovations. There's a book on that. It's an old book, but the concepts of diffusion of and innovation, like how do you get a new drug into practice? There's a physics to that. There's a set of rules, a process that's very, very common for every type of innovation. And I think the second thing you need to do is to imbue that entire community with the knowledge of the true process. Much like if you said, I want to go at the speed of light, I better learn a little bit about physics and relativity theory and energy and things like that before I sit down and build a rocket ship to do that. I mean, because I've got a problem there, but you may not know it if you don't know the theory of relativity. So I think you need to know the theory and practice of the diffusion of innovations. The third thing is, without question, team building and leadership. So that community needs to form into an effective team using processes. So you need a methodology, you need frameworks, you need processes that are well defined. After that, I have no idea. I mean, and I can't tell if they're the top 5. It might be giving everybody coffee at noon is a real answer. I mean, I really don't know, and you guys probably know more about that than I do from it.
When you look at the Calgary project, and I think that's the one that you're mentioning for physician order entry systems, there it was very much a hands-on approach. They used people to interact with people, physicians, to get them comfortable with the system that they were going to use. And they did use coffee. It was one of the approaches. When you look at Diane Beattie's work in London for the shared diagnostic imaging work that she did, there was a celebration after every hospital came online. So again, it was very much a human aspect to the implementation that was then proved so successful.
What we're learning here is that successful eHealth is water soluble, the coffee part of the thing. It's a very important question, and it would make really some excellent studies to actually get the data, because it to the best of my knowledge is aggregated nowhere at this point. So, but I think we again need evidence to do that.
There was a, at eHealth 2006 or 2007, 2006, I think, they had a presentation from the Calgary team that went through all the reasons why they were successful. And it should be in there in the abstracts, in the proceedings. It was in the proceedings from eHealth 2006, I think.
Yeah. And that's just one. There are many, many others that you could use, but very few of them have been, I'll call it, studied quantitatively or qualitatively. So,
I think we're getting close to the end.
Yeah, we're getting
Do we
close
have
to it.
time for one quick question here?
not from him, no.
Actually, it's not a question, more comment to again, just dramatically emphasize my agreement with A, the frustration, and B, the problem with consultants. I was doing that myself for a while, and I found I couldn't even go home and sleep properly at night thinking, because I knew these organizations needed to be building this intelligence in-house, not having it with someone that would leave at the end of a few months or something. And just on that note, I just read just last night an article, and it was totally different topic. It was actually about an application tool that this company is using, but in the context of this article, they shared some numbers that MD Anderson Cancer Center in Texas, and I happen to know a little bit about this application. For more than 10 years now, they've been internally building their own EPR application. They now have 52 full-time employees on that. One hospital, 52, 30 developers, 12 business analysts, and 6 project managers. One EPR app, one hospital. So, you talked about the problem of, how do we get, we've got 3 hospitals in Ireland, 2 on different Meditech systems, 1 on McKesson, and how do we get some consolidation? Well, if you think of the kind of people we'll need to make that happen, it's staggering.
Not the least of which is the leadership of the organizations
Yeah,
themselves.
Yeah.
Because that was proposed some 15 years ago.
yeah.
I mean, this is not new. I spent actually 15 years as a consultant, so I have much lower level of conscience than you do. But the thing,
Took him into academia.
that's right. Actually, my greatest experience this is really just to end it. The greatest experience as a consultant was learning when the client presents you with a problem, the way you'll earn your money is to listen to that problem, but to figure out what the problem really is. That's really the secret of good consulting. And most of the consultants today are hired doers that do whatever the plan says. There's very little that goes into that fundamental asking of fundamental questions about what are we doing, why are we, is that the right thing to do? And if you present that forcibly, people listen and they change. Thanks very much.
Well, thank you all for coming today, and see you next month on March the 11th.